Good afternoon, everyone. It really is just lovely to see you all. So I just want to take that in for a second. Thank you for being here. I put my presentation together in the office, and then on a plane, and then obviously I learned a lot while being here. So some of it is super relevant, some of it maybe not so much. And what I will do is make a couple of points that are significant, I think, before I actually get to the presentation. And if I don't finish, then just, we'll meet again and have a conversation to discuss those issues. So one point that I wanted to make is I was a young social work student at the University of Pennsylvania in Philadelphia, working in an HIV clinic that was early 90s. And I met with doctors that were taking care of women who had HIV. And I've heard a long list of what's wrong with women. They don't come, they're not reliable, they don't take care of their health, they have appointments and miss them continuously. And so the list went on and on and on. And I was sitting there somewhat concerned, again, young kid, just listening, not saying anything. And that was at something that is called HUP, Hospital of University of Pennsylvania. Literally next door to it is something that is called CHAP, Children's Hospital of University of Pennsylvania, and it's a first hospital for children in the United States. And what I started to notice is that, and I was an intern in the Children's Hospital, and what I started to notice is that women were not missing appointments of their children. That we did not have the same experience at all. They were there on time, you never had to reschedule. What I also noticed, that those moms were often coming, sat in a room, and were clearly very distressed, clearly haven't eaten. We would share our lunches with them. Would fall asleep in a chair waiting for the doctor to arrive because they were purely exhausted. So I went back to with my supervisor to the women's doctors, adult doctors, and said to them, how about you guys come in and see those moms when they come in for children's appointments. And let's just do it at one go, and maybe you'll be happier with the way they take care of themselves, and we'll make it an opportunity for everyone. So they sort of said, well, it's two different hospital systems, insurance, how are we going to make it happen? Okay, but let's try it. Let's try it once a week. And those physicians were astonished. They were astonished that every single day, the calendar, the way it looked like, was the way it happened. Women came, the women came for themselves and for their children, and within 3 months, basically, all of the moms, the care of all of the moms were shifted into the children's unit, because that is how they showed up. Because paying for public transportation twice was not possible, because getting childcare when they had their appointments was not possible. And as I was having those conversations with those physicians, they would often say, and drug users are the worst. And so, this sort of thinking of what happens to women, what happens to mothers when they're drug using, where they have healthcare needs, has always been something that sort of stuck with me for now 30 years because of that experience. So that's sort of one point that I wanted to make. Another one, which was also very sort of powerful to me, was when I was in Poland. I'm Polish by birth. I left when I was 18. When I was in Poland, I went to visit drug treatment facility for women and just had conversations with women there. What got you here? How did it happen? Communist Poland was very anti sort of drugs. These were the evils of the West and so on and so on. So I actually grew up in an incredibly sort of prohibitionist, abstinence-based thinking about drugs. So when I had conversations with those women, it was stunning to me how many of them grew up in alcoholic households, abused by their relatives, how much sexual violence there was. And all of a sudden, I started to think that, what? Drugs were not the problem. Drugs actually were a solution for many of them. And this sort of, and as I participated in a meeting earlier this week together with Bernice, we kept hearing, this thing which is drugs bad, drug abuse. I think that's the term that was being used. Drug abuse bad, free of drugs good. And it was very sort of binary. We looked at the research, we looked at the data. This was a gender equity conference. And at the same time, I kept hearing about the violence against women and dramatic stories of women that were coming onto the stage and talking about what happened to them and how they've survived. And again, it was so clear to me that putting drugs in this very binary sort of way of thinking, good, bad, is just not the right way to go. Because for many women, drugs actually are what's saving their lives. Yes, chances are they will get in trouble with it later. That's a possibility. But like any other health issue, okay, let's help them with it. This is a way of coping. And I think remembering that for many women in particular, that's a way of coping, is important because then our relationship to our client, our patient, our friend becomes very different. And so I guess these are the sort of two thoughts I wanted to share with you. So yes, I'll talk about women and drugs, as you might have guessed. So many of you, I'm sure, know that there's something that was called UNGAS 2016. Many of us worked together on preparing for UNGAS 2016. One of the groups that was heavily engaged, National Advocates for Pregnant Women in the US, put together a declaration. Over 100 organizations across the world have signed, and basically that was the sort of leading statement. Punitive drug control policies have especially failed women and families. The current global drug control regime institutionalizes laws and practices that disempower women, violate the principles and values fundamental to women's equality. And so that's a starting premise with which I would like to have that conversation. Now, many of you are engaged in multiple other movements. There are UNAIDS targets, right? No more new infections, everyone on treatment, 100% prevention, and so on and so on. None of those targets will be met if we don't look at drug users. And none of those targets will be met if we do not address the needs of women drug users. Again, some of you are looking at development and MDGs. MDG 1, 3, 5, 16, 17. Those MDGs will not be met if we do not look at women, women drug users and drug users generally. The farmers, the growers, some of the people that we have heard from here. So it's not just about a small community of people that are not getting the service that they need. Basically, global outcomes that 184 nations agreed to will fail because we have not properly addressed the needs of drug users and women drug users. Now, this is what UNAIDS identifies as top 4 reasons for why people with drugs are left behind. Criminalization and punitive laws, absent or inadequate prevention services, I would say services, never mind just prevention, but generally services, widespread societal stigma, and lack of investment on multiple levels. This is a first statement that I saw from actually UN Women in 2016. on questions of women and drugs. Most offenses for which women are imprisoned are crimes of poverty and are nonviolent, property or drug-related. Globally, women are imprisoned for drug offenses more than for any other crime. And I know that a lot of the discussion here, appropriately so, was about treatment. Access to treatment, lack of treatment, whether it's harm reduction services, whether it's good quality treatment. Let's not forget about criminal justice. Women end up in prison for drug-related offenses as the sort of primary category of quote-unquote crime. So, speaking about criminalization and punitive law, what is really, so women who commit low-level drug offenses are more likely to be incarcerated than men that commit major drug trafficking offenses. And it actually, when you think about it, it makes sense. Because if you engage in the drug industry, someone who is totally powerless, a single mom of 3, and that really is the only income that she is able to receive for multiple reasons, then what ends up happening is once she gets stopped by the police, there is no one there for her. There is no drug industry that is going to pay for the lawyers. There is no wife who is going to fight to get you out of prison. Those women are very often literally on their own. I had the pleasure, or maybe pleasure is the wrong word to use, to speak to a judge actually in the United Kingdom who works just outside of Heathrow, the airport in London. That's his jurisdiction. The stories that he was sharing with me, one after another, about women who were, I don't want to say tricked, because it's not about being tricked. I think it's about being in a very vulnerable position and basically grasping for straws and doing what seems as a way out at that particular second. But he was talking about women from Kenya, from South Africa, from multiple African countries that are told, oh, you're a mom of 5. Once you get there, the worst that will happen to you is that they will just take the drugs away and send you back. Well, guess what? 10 years in prison in the UK. And that woman does not have a lawyer in the UK that she can call. She literally has no idea what happens to her kids back home because the door is shut. And, South African embassy, Kenyan embassy, do you think they're that interested in sort of sticking up for those women and making sure that there at least is some message back to their kids? Not so much. So women's low-level role in drug distribution is indicative of poverty, lack of economic opportunities, exploitation, marginalization. Some data about Europe and Central Asia. 31,000 women, 28% across Europe and Central Asia are imprisoned for drug offenses. That's in Europe. Latvia and Tajikistan, more than half of female prisoners are there for nonviolent drug offenses. Now, Russia incarcerates over twice as many women for drug offenses as all of the EU. Now, Mom, we should make a commitment that in a year or two, when we meet again at a gathering like this, we actually will have some African data. Because at the moment, what we are finding in research is mostly North America and Europe. Now, Iran is a story that breaks my heart, repeatedly. Iran executed 684 people in 2015, 70% of the executions for drug-related offenses, 70% of women executed were charged with drug offenses. Now, this picture here will be recognized by those of you that were in the Drug Policy Museum in London that took place about a year ago. The title of this piece of art, this sort of set of art, is Waiting Girls. I'm going to try not to cry as I say it. So in Iran, you cannot execute a person if he or she is not 18. You have young girls, 16, 15, 17, waiting until they turn 18 in prison in Iran to be executed. Most of them, 90% of them, for drug offenses. Something that are very minor drug offenses. So in the US, and I say that, I was actually thinking whether I should just take out that slide because we're not in the US and maybe that's not that important. But I think this basically shows you the sort of, it's about race, but it's also about economic vulnerability. Black women are 10 times more likely than white women to be reported to child welfare services for prenatal drug use, yet their use is basically at an equal rate. Black women are almost 5 times more likely than white women to be sent to prison for drug violation. Drug offenses are the most common reason for maternal incarceration. And pregnant women incarcerated rarely have access to any prenatal care. And I'm guessing that you can tell me stories from your own countries, from your own communities, where race and socioeconomic status in the same way becomes a major issue. Now, if you look at this woman right here, she is shackled to the bed. She delivered a baby and was drug tested at the same time during delivery. So basically what happens now is that she goes to jail, and if she's lucky, her family is going to pick up the baby and is going to take care of it for the time she's in prison. So, I would say that as drug policy develops in South Africa, and as all of your countries are basically making decisions in this area, in Africa as a whole, look at United States for examples of what not to do. Because this is what happens in the US. And, I'm not saying it jokingly. I'm saying it seriously. Because here's what happens. You have someone who has concern for the children, right? We've often heard this. And what about the children? So we have someone who has concern for the children. I'm sure many of you have heard about crack babies. And so what do you do to make sure that, you protect the children and so on and so on. And I'm not making fun of it. I completely understand that sort of instinct. I'm a mom of 2. I would want a sort of serious safety net there if, my life becomes complicated. Of course, I would want to make sure that my kids are in some way protected. But here's what ends up happening in the US, state by state. Because someone raises a question, what about the children? Someone else says, well, let's test mothers when they give birth. Or let's test mothers for drugs when they come to neonatal care or prenatal care. Well, guess what happens? Women stop coming to doctors. Because why would they? Why would they come to a physician if what happens is this? So, we develop solutions that are heartless, and not even meaning it. When you look at the laws and when you look at the debates that take place in US states about those laws, no one says, women who use drugs are evil and we should just lock them up and take away their children. No one says it that way. It's all sort of embedded in this, concern for children. What ends up happening at the end of the day, however, is children are the ones that are not taken care of. Because if mom has no prenatal care, if mom lives in poverty, if mom is being told that they'll take away her methadone if she's pregnant, guess what happens? What ends up happening? She will hide her pregnancy as long as it is possible to hide, right? So we're creating systems that are completely, completely heartless, and at the end of the day are actually punishing that child. So I say it seriously. As you're developing your guidelines, your laws and regulations, if you look to the US in terms of what not to do. And that was one of the examples. Now, in Latin America, more than 60% of women prisoners in Argentina, Brazil, Costa Rica are incarcerated for drug offenses. 90% of them, surprise, surprise, single moms. In Argentina, 90% of women were incarcerated with human courier crimes. This is what Sean referred to, women who are trafficking small amounts of drugs, who are mules. And 96% first-time offenders. The incarceration of women can have devastating consequences for the entire families, as you heard, and children who are left with no economic protection. And many women are indeed co-opted by organizations that operate in similar way that human traffic organizations. Now, I traveled to Guaviare, part of Colombia. That is sort of far. Let's just say that this is not where tourists go. And I went to prison and had a conversation with a woman who was locked up there. She was there for 5 months already. She was a courier for a small package of coca paste. So she was there for months already. She still has not seen the judge. And the expectation is that when the judge will see her, she may get, anywhere from 3 to 5 years in prison. 2 of her kids, and it was a small town. It was a small town, so you can sort of look out the window and see the small almost village. 2 of her kids, she had no idea what's happening to them. Whether they're still in the small house, that sort of makeshift house that they've made for themselves, whether they're somewhere else, because there was nothing. There was absolutely nothing for her to stay in touch with her family. Again, more about Latin America. In Colombia, micro-trafficking is punished more severely than rape or murder. Just think about that. Women in more rural settings participate in drug farming and growing to provide financial support to their dependents. Beautiful coca leaf that we have seen in slides by Dora and David yesterday. And again, often the solution is crop substitution programs. Again, sort of stop and think about that, how those programs are designed, but because when we looked at the data, primary beneficiaries of those programs are men, because they go to agricultural trainings, they get the tools, they receive the credit, not the women. So small women farmers continue to be vulnerable and left with very limited support. The Philippines. As I was putting this slide together, I was sort of thinking, how does that fit in the women and drugs presentation? But I'm so appalled by what's happening in the Philippines that I just wanted to alert you to it, in case you don't know. So first of all, 53% of female prisoners in Philippines are there due to drug-related offenses. And you might know, or you may not know, that Philippines has a president that launched a very violent war on drugs, 27,000 extrajudicial killings. Sorry. And so how does that affect women? Most of those killings are killings of men, of young men, of poor young men. And as much as it is a war on drugs, it's really the war on the poor. And so who is left behind? Women and children that often have no money to pay for the funeral, if they're lucky enough to actually have the body. Now, what's really interesting to me, as I sort of read about the response to Duterte, 2 women senators, brave enough to actually speak out against the war on drugs. Women. One of them locked up, now I think a year and a half ago, for slut shaming. Supposedly she had an affair with her driver. The second one is really very threatened right now because there are some drug charges against her. 3 days ago, an amazing book was described by The Guardian about Mexico, about the 43 killings of 43 young students. Guess what? Written by a young woman journalist. So I think the engagement of women in a pushback in very threatening situations, I actually find incredibly impressive and heartwarming. So absent or inadequate services, this is something that you've spoke about a lot. I would just very much encourage you and to think about how, once those services are up and going, actually, how do they respond to needs of women? Significantly higher mortality rates and increased likelihood of injection-related problems for women, faster progression from first injection, first drug use to dependence, higher level of risky injecting and risky sexual behavior due to gender-based violence. You have 3 separate studies here from 2012, 10, and 2005. Access to affordable, scientifically sound, gender-appropriate treatment is often unavailable. If I were to ask those of you that are engaged in delivering services, how many of you have programs, efforts that are specifically created for women? Anyone? That's not unusual. Bravo, here's one. Lack of discrete and gender-sensitive services keeps many women from seeking treatment, and that obviously is not a surprise. In some countries, pregnant women who use drugs, who seek treatment, actually risk arrest, incarceration, if they're pregnant for the remainder of their pregnancy, and we talked about that. And in the US, because women's drug use is hidden, women are much less likely to be administered naloxone, Narcan, when experiencing an opioid overdose. Women reluctant to seek care for fear of negative judgment and hostile reaction. Mothers who use drugs are separated from their children temporarily or permanently by unjust custody. And just generally widespread societal stigma, and I'm sure I don't need to tell you about that because those discussions have happened here. Culturally embedded power imbalances leave women exposed to increased stigma, abuse, violence, coercion, magnified stigma of women injecting drug users who also engage in sex work, often at the highest risk of HIV transmission. Now, this is a story that some of the Kenyan colleagues might recognize. There's a private foundation in the United States that actually pays $300 to women drug users to get sterilized. And I'll read you this awful quote. "We don't allow dogs to breed. Why would we let women who are drug users?" Basically the assumption. And that story came to, that group came to United Kingdom, and Steve can confirm or not, actually got some traction, but then was asked to leave. That organization is in fact present on the ground in Kenya, and as I understand, in 2 other South African countries. So, limited data and research. Again, I think it would be very useful if all of you, as you develop relationships with us and other funders, think about how to focus on women in terms of service delivery, in terms of research. So how can we make a shift? Gender-responsive harm reduction and generally gender-responsive services. Women-only centers, women-only hours. I mean, I know if we do not have, if a needle exchange program is being closed down, as Sean described, it's difficult to assume there will be another one open just for women. But just have an open, have hours that are women-only. Centers located in areas that are convenient. Education on safe injection, drug consumption, overdose prevention, that is very specific to women. Integrate drug-related services with women's shelters, domestic violence, rape prevention, drug treatment. Address needs of subpopulations, sex workers, pregnant women, women in prison, transgender women, women who have sex with women, and basically promote autonomy through job training, self-defense tactics, legal aid. Just make sure that needs of women are met. Pregnant and parenting women, obviously, drug use should not be basis for losing rights to liberty, family integrity, informed consent, privacy and confidentiality. Combat stigmatizing rhetoric with facts. Keep in mind the importance of maternal bonding when they're small children. Again, in the US, sort of the automatic reaction in the so-called opioid crisis now is, you know, if mom is opioid addicted, should she be breastfeeding? Should we take the baby away? And again, you know, because of the children, because we want to protect the children, the instinct reaction very often is to keep the kids away and provide access to bube and methadone for women with opioid dependencies. Now, in terms of criminal justice, I mean, I'm a big fan. I know Steve here is a big fan of regulation. I'm a big fan of decrim because I sort of feel like this is where most of our countries are at right now. So obviously, my preference would be that women do not end up in prison for small-scale sales for use and decrim. So decrim is sort of my big goal. But if decrim is not possible, recognizing gender-related vulnerabilities should be considered during sentencing. If a woman has 3 kids and no one else at home to take care of them, prison is ever a rational choice. The women who are sellers, small sellers, are very often the way small growers. This is about subsistence allowance. This is not about drug trafficking rings. Provide protection from violence in prison setting and integrate harm reduction in any criminal justice intervention. Now, this meeting that so first of all, the little plants, that's baby coca. Slightly unrelated, but because there was so much aerial eradication in Colombia, what the farmers figured out how to do is that here there are plantations of coca or areas of coca, and then there is a little nursery. So hidden away somewhere, and here's baby coca. So when the spraying does happen, they can replace the plants quite quickly. So that's just one example of how people will adapt to the most insane policies that are implemented. But the picture on top is a first meeting of women growers that just happened in Mexico City. And people there, and women there were women, opium growers, cannabis growers, coca growers. And here are some recommendations from them to us. Promote leadership of female growers. Crop substitution and rural development programs should offer women soft credit, land titling, and seed funding. Straight from them to us. Promote political participation of women coming from areas where coca, cannabis, and opium poppy are grown. And recognize petty trafficking for what it is, a form of securing basic economic survival. So let me just end with the following. That I have an incredible privilege to work at a place that supports debates about rational drug policy. And because of that, I have incredible privilege of meeting all of you, of supporting initiatives that are questioning the current drug policy regime. I think as we articulate a strategy, whether it's decrim, whether it's longer-term regulation, it is really crucially important that in that process we take on other societal inequalities, whether it's race relations, whether it's gender equity. Because if we don't pay attention to what the drivers of injustice socially is, drug policy can also replicate all of those dramatic inequalities. And so as you think about it, and as I look at countries that are just sort of stepping into that water, I really encourage you to push us as your supporters, as your funders, to make space for you to take on gender inequalities, racial inequalities, and teach others in other regions of the world. There's so much that United States drug policy can learn from in other parts of the world. There's so much that European drug policy can learn from many of you. So when you think about drug policy, think broadly and make sure that all of those other issues are properly put in perspective and addressed. Thank you.